Welcome to Derm Boot Camp with Dr. Boswell. Today we're going to go over an overview of the skin. And while this can be a little bit intimidating to describe all the structures in the skin, it's important to at least give an overview as we talk about the disease process that we'll learn about in future lectures and how it involves the different layers and structures in the skin. So behind me on the whiteboard, we have a simple diagram of the skin. The skin is made up of three layers. There's the epidermis, or the first layer of skin, the dermis, and the subcutaneous fat. Let's start with the epidermis. We see here in the epidermis, it is made of cells called squamous cells. These are the normal sort of brick and mortar cells of the epidermis. They're also known as keratinocytes. They make up the wall of the epidermis, all of these. Here at the basal layer, this bottom layer of squamous cells, or this basal layer here at the bottom of the epidermis, these are called basal cells. You can see how, for example, squamous cell carcinoma arises from these cells, whereas basal cell carcinoma is going to arise out of this basal layer cells, which are basically giving rise to new keratinocytes all the time as the bottom layer or the basal layer of the epidermis. Here, every 10 cells or so at the bottom of the epidermis, we have something called melanocytes. Melanocytes are pigment-producing cells that make little packages of pigment called melanosomes, and they send that pigment up to the surface of the skin to protect us against UV radiation. So as we make more pigment, a patient's skin is tanning, for example, that's the melanocytes cranking more melanosomes, sending melanin, the pigment, up to the surface of the skin to protect against UV radiation. In between each keratinocyte, if we blew this up and took these two keratinocytes and looked at it, you would see two large keratinocyte cells with nuclei. In between those two keratinocytes is a protein called the desmosome. All this protein is basically the glue in between keratinocytes, that intercellular glue that keeps these squamous cells together. That becomes important later on when we talk about diseases like pemphigus. This desmosome is either made of a protein called desmoglein 3 or desmoglein 1. Don't worry about that too much right now. It'll become more clear when we talk about pemphigus. Just know that these are the proteins that make up the desmosome, the intercellular glue or protein between individual keratinocytes in the epidermis. Here at this intersection between the epidermis and the dermis is something called the dermal epidermal junction, or the DEJ. We also call that the basement membrane zone. You're going to see that written a lot in textbooks. The dermal epidermal junction is this area right here, also called the basement membrane zone. Here, if you blew up this bottom cell, you would see the bottom half of it with its nucleus sort of anchored here to the dermis. This anchoring, this protein that is anchored here with the dermis just below, is something called the hemidesmosome. The hemidesmosome is basically the anchor that is a protein that helps the epidermis stick to the dermis. When we talk about diseases like bullous pemphigoid, we're going to talk about how that hemidesmosome is attacked in an autoimmune manner, splitting the epidermis and dermis, creating a blister. So it becomes important later on. Let's go back here to the epidermis. We know that melanocytes, every 10 cells or so making pigment, that gives rise to cancer. That's called melanoma. If it gives rise to benign collections of melanocytes, That's called a nevus, or plural is nevi. Let's now look at the dermis. The dermis is separated into the papillary dermis and deeper, the reticular dermis. It's easy to remember papillary because you can see this finger-like projections or papilla, derma papilla, going up to meet the downward grooves of the epidermis. So up high we have the papillary dermis, deeper is the reticular dermis. In the dermis we find the majority of the hair follicle. The hair follicle goes down deep into the dermis, in here the reticular dermis, almost pretty much into the fat. We see here in this hair follicle there are hair matrix cells. These are cells that give rise to new hair follicles and proteins. It's always sort of giving rise to new hair. That's the hair matrix. The medical word for hair is pylo. So for example, there are some tumors that we see in children called a pylomatrixoma, or in other words, a hair matrix tumor. Sometimes we call it a pilomatrixoma. A pilomatrixoma or a pilomatrixoma is a hair follicle tumor that arises out of these hair matrix cells that go crazy and turn into a benign growth, again known as a pilomatrixoma or a pilomatrixoma. We see that the hair follicle is connected to an oil gland, or otherwise known as a sebaceous gland. A sebaceous gland is always connected to a hair follicle. Together, this apparatus is called a pilosebaceous unit, because hair follicles and oil glands always go together. For example, acne is a disease of the pilosebaceous unit, which we'll learn about in a different lecture. There are several diseases that involve the sebaceous glands. Sebaceous hyperplasia is a benign overgrowth of these oil glands that turn into these sort of pilosebaceous tumors. Very common little yellowish papules on the forehead and medial cheeks of the middle-aged and the elderly. We also see that seborrheic dermatitis involves a yeast called Malassezia furfur that lives in the sebaceous glands. We see a disease called pityriasis versicolor. It's been misnamed as tinea versicolor. Involves Malassezia yeast that overgrows out of the sebaceous gland up into the top of the skin to give a rash. We'll talk about that in our fungus lecture. But you can see that the sebaceous gland certainly carries an important role in dermatology and in disease. Here we have blood vessels also in the dermis. And we know that blood vessels run along with nerves. So we'll put blood vessel and we'll say nerves. We know that, for example, when you inject lidocaine into the dermis, they say ow because you injected it right where the nerves are. We see some nerve tumors like neurofibromas and some other growths originate in these nerves. We also see blood vessels that get attacked in an autoimmune way, where white blood cells will attack blood vessels deep in the dermis, giving a disease called leukocytoclastic vasculitis, or we'll just say vasculitis for now. Again, don't worry about all these diseases right now. We're just talking a general overview of how these structures in the skin pertain to these diseases that we're going to learn about. Over here in the dermis, we also have a protein that makes up the majority of the dermis. It is called collagen. We all know if you want to look like Angelina Jolie, you go to the cosmetic dermatologist and go get more collagen injected into those lips. It's a main substance of the dermis to provide volume, including cosmetically, to the skin. There are some autoimmune diseases like granuloma annulare, which we'll learn about later, where the immune system attacks collagen and eats it up and makes these rings on top of the skin, these annular plaques on the dorsal hands, dorsal feet, giving rise to granuloma annulare. That is the immune system munching up and eating collagen in the dermis. Here we have some immune system cells. We have lymphocytes, which are B and T cells. We also can have neutrophils. These are type of white blood cells that are always sort of surveying the skin. There'll be a lot of times where a pathology report comes back and you're reading about infiltrates and white blood cells, lymphocytes, neutrophils. These are the players in the skin, these type of white blood cells that sometimes get overactive in the skin. For example, neutrophils go crazy here in the papillary dermis in something called Sweets syndrome. T cells and B cells are very much involved in lichen planus. Again, running here through the upper or papillary dermis. We see here structures called sweat glands. These are eccrine and apocrine sweat glands that are tied to the epidermis to let go of their secretions. And we see certain diseases, for example, of the apocrine sweat glands like hidradenitis suppurativa, which happen in the axilla, inguinal areas, these areas where we have a lot of these apocrine sweat glands. We know that eccrine sweat glands are a lot in the palms and soles. Those are the ones that make us have sweaty palms and soles, but they're basically located throughout the body. Here we have something called a macrophage. When a macrophage that gobbles up foreign bacteria, germs, bad stuff, something it doesn't recognize by way of phagocytosis, which you learned about in your immunology classes in nursing school, in PA school, in medical school, in college. These macrophages are in the dermis and they can gobble up bacteria, but they can also gobble up pigment. When they gobble up pigment that's been dropped from the epidermis, they're called melanophages. You might see that on a pathology report. If they gobble up lipid, they're called foamy macrophages because they're engulfing and phagocytosing lipid. If they're engulfing iron, we call that siderophages. They're gobbling up iron. For example, if you biopsied stasis dermatitis or post-inflammatory hyperpigmentation on the ankles or lower shins of somebody with chronic stasis dermatitis, the pathologist will comment on some siderophages, again, macrophages that are gobbling up iron. When a macrophage in general is in the tissue, in the dermis, they're also referred to as histiocytes. So that can be confusing. What is a histiocyte? Histology is the study of tissue. So when you see histiocytes, don't be alarmed. Just think of histiocytes are basically macrophages in the skin. They're the same thing, okay? They're phagocytic cells that eat up foreign material. Let's now move into the fat. In the fat, we have a lot more space. There are large lobules of adipose tissue. Sometimes we call this the subcutis or the subq. You don't have a lot of nerves there. And so if your lidocaine needle is numbing up the patient and ends up there, they're going to say, ow, because it's in the dermis. That's fine. If you actually sink the needle in a little farther, it goes in here to the fat. And they won't hurt as much because there's no real nerves in the fat. We also have septae that are in between all of these fat lobules. And so that comes into play when we talk about paniculitis, such as erythema nodosum, which gives a lot of inflammation on the septae in between the fat lobules. Now let's talk about another cell in the dermis. There are also cells called mast cells. Mast cells live in the dermis, and one of the things they do is they release histamine. So when you go out into the pollen or the ragweed or the pet is nearby and you're allergic, your mast cells release a ton of histamine into your skin and into your system. And so you get sneezy, you get itchy eyes, and you need to take an antihistamine like Benadryl, Claritin, Zyrtec for those symptoms because of all the histamine that's been released from those mast cells. This is important because mast cells give off a lot of histamine in conditions like hives or urticaria, which we'll be learning about. Also, there are benign growths called a mastocytoma. A mastocytoma is a benign thing we see in kids where that mast cell turns into a tumor, a benign, harmless tumor, sometimes on the arm or on the neck, this yellowish brown growth called a solitary mastocytoma that if you rub it, it'll swell because you just rubbed it, activated a big tumor of mast cells to release all that histamine in the skin, giving some swelling called the Derrier sign, which we'll talk about at another time. One last thought about the fat and the dermis. Before we leave this dermis and fat, you'll notice that the hair follicles, the bottom of the hair follicles, are pretty close to that fat layer. So there's a condition, for example, called alopecia areata, this autoimmune attack on the hair follicles that gives alopecia, these thinning areas, bald spots on the scalp, like big circles, which we'll talk about in another lecture, in our alopecia lecture. Well, that attack on the hair is actually happening down here at the bottom of the hair follicles like a swarm of bees. These lymphocytes are attacking right there. So for alopecia areata, when you do intralesional Kenalog injections to treat that and to calm down that autoimmune attack deep in the dermis, right here at the bottom of the hair follicle, when you inject that steroid Kenalog, there is a chance that you'll actually get some fat atrophy. That Kenalog will dissolve away some fat, potentially giving them a little bit of divot left over on their scalp where you injected them. We call that golf ball head, but it is a side effect of Kenalog injections, potentially, especially if you're using too high of a concentration. But the reason for that is because we're targeting this area right here, deep in the dermis, the bottom of the hair follicle, and it's close to the fat, which is basically a little bit of collateral damage when you inject that Kenalog steroid. Next, let's talk about some pathology terms. When you do a biopsy on a rash and you get that pathology report back, it can be very intimidating as the pathologist is using these big, scary, sort of unfamiliar words if you don't have pathology training. So I'd like to describe what the pathologist is describing to you and what these terms mean on those pathology reports you get back. So here you can see some very common patterns that are on pathology reports. Here we have our structure of skin again. Let's talk about this acanthosis. Acanthosis, for example, in Acanthosis nigricans, is actually a pathology term. Acanthosis simply means thickening of the epidermis. And so when a patient comes with those hyperpigmented velvety plaques on the back of the neck, in the armpits, and you say, hey, that's Acanthosis nigricans, we think there's something to do with insulin resistance in some of those patients. Often it can be just hereditary, by the way. What does that mean, Acanthosis nigricans? Well, basically, not to get too much into it, there's an insulin-like growth factor that is secreted that basically somehow influences this skin, this epidermis specifically, to get thicker and thicker and thicker. And so when you biopsy Acanthosis nigricans, the pathologist, he or she will describe a thickening of the epidermis. When you look at a patient with that condition, Acanthosis nigricans, it's actually thickening of the skin, not darkening of the skin. So when a patient says, give me some bleaching cream for my Acanthosis nigricans, or maybe I can clean this and get the dirt off, it's not dirt, it's actually not pigment. It's actually thickening and sort of this wavy change that the epidermis does to thicken it to the natural eye. Clinically looking at that neck, it appears as dark, but it's actually not dark, it's actually thickened skin, again, thought to be due to insulin resistance. What about acantholysis? You might see acantholytic, like transient acantholytic dermatosis, also known as Grover's disease, a very common heat rash in the middle-aged men. That's basically where these keratinocytes are falling apart. They're letting go of each other, letting go of their neighbor squamous cells or neighbor keratinocytes, acantholytic or lysing, and falling apart. So acanthosis is a different term than acantholysis. What about psoriasiform dermatitis? What the pathologist is communicating is that they see this elongation of reedy ridges, elongated epidermis ridges going down, matching elongated papillary dermis projections going up. They're also seeing little neutrophils or white blood cells in this upper cornified layer of the epidermis. Why do they see neutrophils and white blood cells? Is psoriasis an infection? No. We know that these cytokines like interleukin-8 recruit neutrophils. And so that silvery scale on a psoriasiform plaque on an elbow, what is that whitish scale on the very, very top? That's dried pus. Absolutely. It's dead neutrophils or dried pus. If you biopsy that psoriasis, the pathologist sees dried pus or dead white blood cells here in the very top layer and elongated reedy ridges, or in other words, psoriasiform dermatitis. What is interface vacuolar dermatitis? We see that sometimes with lupus and dermatomyositis and some other conditions. Here at the interface, that means here at the interface between the epidermis and the dermis, right here, it's separating a little bit and making big spaces like vacuoles within the keratinocytes. You remember vacuoles in your biology class are these storage containers in these cells, these organelles that sort of look like big sort of empty spaces within the cell. So they see these cells, these keratinocytes, having little vacuoles over them and a little bit of separation and irritation here between the epidermis and the dermis. Again, you might see that with cutaneous lupus or other connective tissue diseases like dermatomyositis. Let's talk about this one. This is one of the most important ones to talk about. Spongiotic dermatitis. What is this spongiotic dermatitis? Understand that when you do a punch biopsy on eczema, allergic contact dermatitis, nummular eczema, dyshydrotic eczema, any eczema type process, when you biopsy it, the pathologist will never give you a read that says eczema on the pathology report because it just doesn't happen. What they will do is they'll say spongiotic dermatitis. They might say vesicular spongiotic dermatitis. They might say subacute spongiotic dermatitis. What does spongiotic dermatitis mean? Spongiotic dermatitis means these keratinocytes are enlarged and swollen, almost like a sponge that took on water. They're spongy, they're swollen and big. And all these keratinocytes being a little swollen will be a read of spongiotic dermatitis. And then you'll get a little paragraph under that from the pathologist saying, note, spongiotic dermatitis can be seen in allergic contact dermatitis like to poison oak and those kind of things. It can be seen with inherent eczema, whether the conventional atopic dermatitis in the flexural areas. It can be seen with nummular eczema. It can be seen with an eczema-like reaction to a medication. Basically, the pathologist is saying, you figure it out as the clinician. That's just the pattern that I see under the microscope. So clinically, we would never tell a patient, you have spongiotic dermatitis. That's not an answer clinically. We've got to figure out, okay, it's in the eczema sort of contact dermatitis maybe category. Let's see what fits with what I see with my eyeballs here on the patient in the exam room. So don't let spongiotic dermatitis confuse you. Never tell a patient they have spongiotic dermatitis because it's a pathology term consistent with eczema type processes. If you want to think that as loosey-goosey eczema, that might be helpful. What about granulomatous dermatitis? Granulomatous dermatitis, again, are these macrophages, or you'll remember from a few minutes ago, these are histiocytes, the same thing. Macrophages in the tissue or in the dermis are also known as histiocytes. These are basically swirling around something, and they're reacting. They're deep in the dermis. All these macrophages or histiocytes are getting granulomatous and swirling around some sort of stimulus. We see this sometimes with granuloma annulare or sarcoidosis, different types of granulomatous inflammation. Again, not in the dermis. It's usually here deeper in the reticular dermis. What is lichenoid dermatitis or a lichenoid process? Lichenoid, clinically to our eyes, looks like mold or lichen on a tree. That's what it was named after. Lichen planus, for example, can look like that, or lichen simplex chronicus. It doesn't mean the patient has mold or a lichen growing on their skin. It just means to our eyes we see these increased markings, sort of a lichen-like appearance. But it's also a pathology term. So when a pathologist says lichenoid infiltrate, what does he or she mean? What they mean is that they see a bunch of lymphocytes, B cells, T cells, that are basically going through the upper layer of the dermis, or in other words, the papillary dermis, as a lichenoid infiltrate of B cells and T cells. We see that with conditions like, again, lichen planus and other conditions that have lichenoid infiltrates. This is usually an autoimmune process where these lymphocytes are racing across that papillary upper level of the dermis for some unknown reason in an autoimmune way. Sometimes what happens is they do it so severely that these melanocytes, again, every 10 cells or so, here at the bottom layer of the epidermis, these lichenoid infiltrate will go so abruptly that these melanocytes dump their pigment. Basically, that lichenoid infiltrate drops the floor, takes the floor out of these melanocytes, and they drop their pigment deep into the dermis. That's called pigment incontinence. So a lichenoid infiltrate will often make the melanocytes pee their pants, be incontinent, and drop their melanin down into the dermis, which is why after a lichenoid eruption, like a lichen planus, it stays dark for so long. That melanin does not appear anymore. Those melanocytes were incontinent because the floor was taken out under them, and that melanin is now deep in the dermis. In fact, a macrophage might gobble it up, becoming a melanophage, and that might require some laser treatment or just a lot of time for that pigment to fade clinically. Lastly, to conclude this lecture, let's talk about how to look at the skin clinically there on the patient in the exam room to be able to formulate a differential diagnosis based on purely how the skin looks, based on our knowledge of the 3 layers of skin and the properties of each of those layers that we've discussed. Let's first remind ourselves and talk about the epidermis. Epidermal diseases, when you're looking at the patient, are scaly. If you look at the examples I've written here, actinic keratoses, squamous cell carcinoma, basal cell carcinoma that kind of gets necrotic and scabby, or even a superficial basal cell carcinoma, which can be scaly, eczema, psoriasis, tinea or a fungus infection, that fungus is right up here. It's not down crazy in here. It's right up here, top of the epidermis. So when you're looking at a rash and you see that it's dry and scaly, you can say, aha, this is going to be an epidermal disease. These annular, scaly plaques that are spreading on these inner thighs, I know they're annular. That's probably tinea cruris, and I need to do a KOH because it's scaly, and I know that's an epidermal disease, as opposed to granuloma annulare, these annular dermal plaques with no scale. That's a dermal process. So when you're looking at these and you're freezing AKs, you're looking at seborrheic keratoses, tinea, eczema, scaly, that is an epidermal disease differential. We're here in this category. What happens in the dermis? What are dermal diseases in dermatology? Dermal diseases, by definition, are well-defined. In other words, the process pops out at you with no scale. So if you think about hives or urticaria, you have these individual welts. Urticaria hives pop out, and they come and go over the days, and they're coming and going, and they're welts. This is a dermal disease, and we know that because that's the histamine being released from mast cells in the dermis, which is why for urticaria, you're not going to give a topical steroid. Topical steroids don't help urticaria. Topical steroids dissolve maybe that deep. They're more for epidermal conditions. Topicals are more for epidermal conditions, whereas we would give antihistamines, pills for urticaria and other treatments because we know it's a deeper process. Again, it pops out like a hive. Another example is think about all the PPD or tuberculin sort of tests you've done or you've seen. When you get a PPD test on your arm and that little injection happens, it welts up really clearly as this little white bubble almost. You just deposited that tuberculin right there in the dermis, not in the epidermis, not in the fat, because again, in the dermis, there's only so much room. There's collagen, there's blood vessels. If you put anything extra in the dermis, like lidocaine injection or a PPD tuberculin test, it's going to jump out at you and look like a hive because again, there's no extra room for anything in the dermis. It's already packed. Granuloma annulare will pooch out like an annular plaque with no scale. These are these annular plaques on top of the dorsal hands, sometimes dorsal feet, elbows, over joints. Again, happening here, surrounding collagen, eating up collagen in the dermis. A great example of a well-defined, non-scaly dermis disease. Same is true of sarcoidosis, not just pulmonary, but there's cutaneous sarcoidosis, which is happening in the dermis. Sweet syndrome is where neutrophils, a type of white blood cell, in an autoimmune way get activated and all run here along the papillary dermis. Very excited. Sweet syndrome in general is not scaly. It pooches that skin up as erythematous juicy nodules and papules. Again, an upper or papillary dermal disease. Sweet syndrome happens in the dermis. We've talked about the lidocaine wealth. What is erysipelas? Erysipelas, often confused with cellulitis, is not a fat disease. It's happening in the dermis. It is a group A strep infection of the dermis. So if you see pictures of erysipelas, it will pop out at you, this erythematous, bright red plaque on the lower leg, or sometimes on the face of an old lady you'll see in a lot of dermatology atlases and textbooks. That is basically strep growing in the dermis. Again, there's no room. So what will happen is it'll swell and be very bright, where you can absolutely see where that erysipelas is happening right next to normal skin where it's not happening, because it's a dermal disease. That strep is infecting the dermis, not the epidermis and not the fat. Erysipelas. Tumor lupus is a type of dermal lupus, skin lupus, that basically looks like hives on the chest or on the trunk. Can be mistaken for hives sometimes, but is a dermal form of cutaneous lupus. So well-defined, pops out, even will sometimes blister because there's no room. Sweet syndrome can blister. You can see erysipelas blister because there's no room for anything else in the dermis when it gets packed with inflammation. Lastly, let's talk about fat diseases. When you're looking at a rash and you see that the margins or the surrounding areas of that redness or erythema in the skin is poorly or ill-defined, it's kind of subtle, that's because that disease process is happening deep down in the fat. So why, when we admit a patient for cellulitis, do we outline it with pen? Well, yes, to see if it's progressing and getting worse, but the main reason is at the beginning is also because we can't really tell where it begins and ends. It's sort of hazy, fuzzy, we can't tell. That's because cellulitis is a deep process in the fat. If you asked your healthcare provider friend, just quiz him or her and say, hey, how many patients with cellulitis have you admitted and taken care of? Oh, dozens. Where is that infection, cellulitis? Is it in the epidermis, in the dermis, or the fat? Where in the skin is that happening? Most patients or most providers will say, I think that's happening in the dermis, and they're wrong. That's erysipelas. Cellulitis is an infection of the cellulite. So cellulitis is actually happening down here. The staph and strep are growing in the cellulite. Nobody likes their cellulite. So literally cellulitis is an infection of the fat layer of skin, which is a deep process, which is why it's so hard to see where it begins and ends. Very hazy, fuzzy borders. You got to put a pen because it's different than erysipelas, which really pops out at you. There are different types of paniculitides or paniculitis. Paniculitis is not infection of the fat. Paniculitis is inflammation of the fat. So there's no infection, but you have lymphocytes and other immune cells reacting either in the septae between the fat lobules or in the lobules themselves. A classic example of paniculitis is erythema nodosum. A great example of paniculitis where you get these erythematous, tender nodules on the bilateral shins, lower extremities. In fact, erythema nodosum sometimes look like little skip areas of cellulitis. Well, that's crazy. You would never get cellulitis, then nothing, then cellulitis, then nothing. Those little skip areas, erythema nodosum, kind of looks like skip areas of cellulitis because they're both fat diseases. They're in the fat layer. So erythema nodosum, inflammation of the fat. You would never do a shave biopsy, for example, to diagnose erythema nodosum. It's a deep process. You've got to do that punch biopsy to show the pathologist some fat, which is where the money is for that diagnosis. There are other types of paniculitis, lupus paniculitis, sclerosing paniculitis, also known as lipodermatosclerosis, pancreatic paniculitis that we see rarely with people with pancreatic disease. So hopefully we've provided a way for you to look at the skin and formulate a differential diagnosis and not be confused between tinea and granuloma annulare, for example, even though they're both annular and they're clearing in the center. One is scaly, one is not. And so knowing the anatomy, knowing the structure of the skin helps you formulate what's going on clinically when you look at these patients. We look forward to going through all these disease processes with you in Derm Boot Camp, and this provides a framework today talking about the basic function and structure of the skin. With that, we'll see you next time on Derm Boot Camp with Dr. Boswell.